Get started.
Yep.
I'm Nicole O'Donnell, a certified recovery specialist at Penn Medicine, and we'd like to thank you all for joining our second of a series of webinars highlighting the implementation of peers with lived experience joining the multidisciplinary team at Penn Medicine to provide evidence-based compassionate care of patients with opiate use disorder. Our housekeeping tips are everyone is muted to mitigate background noise. Please feel free to utilize the chat to put your questions in, and we'll save time at the end. Hopefully everyone knows where their respective bathroom is. And on that note, I will defer to the expert panel to introduce themselves.
Hi, I'm Kelly. I'm a certified recovery specialist. I work at Penn Presbyterian Hospital.
Hi, I'm Angela. I'm the social worker in the emergency department at Pennsylvania Hospital.
Hi, I'm Rachel. I'm a nurse in HUP's emergency department and at Prevention Point, Philadelphia.
And lastly, my name is Dr. Josh Glick. I'm one of the emergency medicine physicians, and I work at both the University of Pennsylvania and Pennsylvania Hospital. I must admit that I am far less qualified than the three wonderful providers who just introduced themselves. But throughout this talk, we're going to give you a little bit of oversight into what we've done to really change our care in the emergency room. And just as a quick aside before we start, I thought I would just honestly admit at the start of the lecture that personally, as a provider, as recently as 5 to 10 years ago, I've been really guilty of the stigma that we're going to talk about in this course. And I personally have spent a lot of time trying to change my own behaviors. And so I think that's what I really am going to bring to this talk. And so just for the sake of honesty, the three other providers on this talk are absolutely wonderful and have always been wonderful. I've had to make some changes to my own behavior. So I just want you all to know that moving forward. The next slide, Kelly's going to give a little bit of an introduction about the certified recovery specialist role.
Thanks, Josh. Yes, first I would like to say I'm grateful and honored to have the opportunity to share my experience and with everyone on this call. I know everyone listening today or supporting people in recovery, whether it's following them with a case manager, provider, family member, and who work in this field, all do amazing work. And I'm a certified recovery specialist. Certified recovery specialist is someone that has lived experience with the disease of addiction. I am a certified peer specialist with mental illness as well. This is a course that I took that's 78 hours, and you have to have the 18 months of recovery with, you have to keep up your credentials with the 36-hour, 24 CEUs for 2 years in order to keep your credentials. That's just a background on certified recovery specialist. I also was hired under a program called CORE, which is the Center of Opioid and Recovery and Engagement, which was made and started up by amazing people that knew that this was going to be a fundamental part of the hospital system. And I'm just honored to be a part of that whole program that started through the Center of Opioid and Opioid Recovery and Addiction Medicine. That's about all I have. And that next.
All right, so this is a pretty phenomenal team, and we are very grateful that Kelly is here to help kind of share her perspective on this. But as a team, we wanted to start by outlining the challenges that exist in the emergency department for folks who use drugs, and then how a peer or CRS like Kelly helps these patients navigate that environment, but more importantly, change the environment. And we'll start by talking about stigma, because this is really fundamental to the challenges that people face. Next slide. So historically and into the present, ERs are not considered safe spaces, certainly not supportive places for people who use drugs. And we all understand this intuitively. I think if you take a minute to, really imagine telling even someone you trust that you have an addiction, say that you're struggling with heroin use, that would be very hard. And now imagine explaining this to a nurse or a doctor who's a complete stranger to you in the ER. And that kind of shudder we all just collectively experienced is because we understand the blame and the lack of respect and understanding that society and certainly healthcare environments inflict on people who use drugs. And it comes out in the ER in a lot of concrete ways. So, for example, say a patient comes in after an overdose. You can advance to the next slide. The first thing is we use disrespectful language when talking about them. So the medically accurate and current way to talk about this would be a patient or a person with a substance use disorder or OUD. And instead, we still often say the guy in 30 with who's a drug user or an addict. And our words matter, so they really contribute to the patient experience, but also how we think about this person as an addict or as a person who's struggling. And in addition to our verbalized words, our body language matters. So looking people in the eye, giving them our undivided attention, these kinds of gestures that let people know that we're invested and we care. We're not in the habit of doing this. And it has a lot to do with how we judge people who we know are using drugs. And so back to the overdose scenario, we as clinicians often make judgments about what this person values and cares about. So, oh, he must not care about his health because he does drugs. And since he overdosed, he must be reckless and not care about his future because he let this happen. And then on the discharge paperwork that I, as the nurse, give this person, it'll say something along the lines of stop using drugs or you'll die. And that's awfully insensitive, obviously. And we know that addiction is not that simple and that people are not that simple. So, and the ER is like the front door to healthcare, especially for people who don't have a ton of resources. So if we don't offer a safe and supportive place for people, where else can they go? They don't have a lot of other options. Next slide.
So the experiences that Rachel was just explaining that these patients have been through leads to a lot of health system trauma and mistrust. Patients have experienced the stereotyping and the disapproval from providers or the care team. And they can be really traumatic, of course. And one of the biggest consequences of that is then they stop coming to the hospital. They don't want to come and get care because they don't want to feel worse. And then what happens is, their infections get worse and their health continues to decline. That's because they don't want to deal with the stigma and or come up as drug seeking. And the only way to really rebuild that trust is to have a team approach of positive culture change within the entire interdisciplinary team. And I think the peer specialist, Kelly, she really is an influential part of that process. Next slide.
So backing up just a little bit and taking into consideration those thoughts, I think, speaking as a physician, but I think speaking on behalf of all emergency providers, every single one of us comes into work every day with the goal and the ideal that the ED, the emergency department, is the great equalizer. It doesn't matter who you are, how much money you have, where you come from, everybody gets the same care. I mean, that's always been our mantra, or at least my mantra. The sad reality is that is in no way true. And in the context of the patients we're talking about today, as you heard from both Rachel and Angela, patients with opiate use disorder really get inferior care up until this point, and honestly still currently. They oftentimes their pain gets dismissed, their symptoms get dismissed, they get ignored. These patients oftentimes will sit for long periods of time waiting to be seen because their problems are felt to be inferior or not real. And so, going back to that original mantra of, the ER is the great equalizer and everybody deserves the same amount of respect and everyone deserves the same level of care. We really need to kind of break down some of these stigmatizations, some of the use of language and the way we treat these patients if we really want to provide them with the same degree of care that we do all of our other patients. Next slide. And so moving forward and to talk a little bit about how the implementation of a certified recovery specialist really helps. I think one of the biggest things is through building bridges. So as an emergency provider, I have no personal experience with opiates or opiate use disorder. I don't understand that patient's background. I've not lived their experiences. And that can make it really challenging for me to kind of meet them on their level. If I don't know where they're coming from and I don't know the circumstances that have brought them to my ER. So one of the biggest things, at least initially and up front, that Kelly and her colleagues do is really help me as the provider understand where this patient's coming from and what they need, right? What I think the patient needs may not be the complete picture. And so Kelly can really help me understand what the patient needs in terms of medical care, but also in terms of their opiate use disorder, and really helps foster a degree of trust between physician and patient that has historically been honestly pretty lacking, to be honest. Next slide.
And another really beautiful thing that results from this bridge building by the CRSs is that health providers see that they see this other way to approach people who are using drugs in their healthcare. The CRSs model this sort of new way, which is really important for moving people to what I call the good side. Like Josh mentioned in his intro, I did not come from the womb thinking about drug use the way that I do now. I learned things, I saw things, and I had really excellent role models. And I've seen among my own colleagues how our CRSs do this. So, for example, a nurse I work with saw the way that Kelly interacted with a patient that they were taking care of. They saw how that patient was more relaxed and engaged as Kelly built rapport with them. And that nurse walked away with a whole new vision of what empathetic care towards someone who uses drugs looks like, and the positive effects it has on everyone. And this is how culture change happens. So in healthcare and more broadly, where person by person, substance use is increasingly seen through a lens of medical accuracy and empathy rather than as a moral failing and with judgment. Next slide.
So that gave you kind of a little bit of background in terms of some of the things we want to change in the emergency room, or we feel are important to change, as well as kind of how the recovery specialists really help us implement those changes. I think one of the more concrete ways we can kind of demonstrate that is we wanted to give you two real patient examples that have we've seen in the emergency room in the past couple months. To kind of highlight how historically these patients may have been treated or met in the emergency room, and how, as a team, honestly led by Kelly and the other recovery specialists, have really altered our own behaviors in the emergency room so that we've really been able to implement much more positive outcomes for these patients. So next slide. So we'll start with case one. So again, this is a real case. Her name has been changed. The details have been removed, but this is a case of Sarah. Sarah was brought to the emergency room for a neck abscess. Slide. So I'll start with the physician perspective on this. So Sarah, I had heard or knew up front that Sarah had a history of opiate use disorder. She injected opiates regularly and had recently started injecting into her neck. And as a result of that, developed an infection in her neck associated with a really large abscess, which is a really dangerous place to get an abscess and an infection. Kelly will talk after me, and she's going to explain a little bit where the patient came from and how she brought her to me. But historically, when I see a patient like Sarah, the vast majority of my time, the vast majority of my mental energy is going to treating what I viewed historically as the medical problem in front of me. So neck infections are bad. They can have really bad consequences to someone's downstream health. And so my initial thoughts are, how sick is this patient? Does the patient need antibiotics? Do they need surgery to drain their abscess? Do I need to drain the abscess? Do I need to get CAT scans? Do I need to get blood work? I'm trying to think about all of these different questions in my mind from a medical perspective, all while taking care of 10 to 20 other patients in the emergency room. And so the amount of mental bandwidth that I have for kind of what I've historically viewed as secondary problems, such as opiate withdrawal, is fairly limited. And so you can imagine historically a realm where the ER physician focuses very quickly on getting antibiotics and calling surgery. But 12 hours later or 24 hours later, the opiate use disorder has been completely ignored. The patient starts going into fairly severe withdrawal. And historically, patients such as Sarah would have gotten frustrated with their withdrawal symptoms and would have left against medical advice. And in a case of a neck abscess, that can have devastating consequences to her health. And so, again, from my perspective, having the role of a peer specialist or recovery specialist with Sarah in the emergency room really allows an additional hand to kind of identify some aspects of her care that I may not cover, and then help me in making appropriate decisions about how to treat those issues. So in this case, what is the patient eligible for medical assisted therapy such as Suboxone or methadone? Does she want those drugs? And so those are questions that historically I would have never even thought about or asked, but that in the more modern environment that we are implementing are being asked by someone else and then being communicated to me, which really frees me up to continue to do the work that I do in the emergency. Next slide.
Thank you, Josh. Yes, this particular woman, I worked in the community as a CRS before I came to the hospital in a harm reduction community, which I was familiar with this young lady, but normal calls I would get, it doesn't really matter. I work particularly with Rachel, who works with this harm reduction community that Prevention Point has a wound care that patients are able to come in during the day and have their wounds addressed and looked at and evaluated. And, that builds a lot of trust because that's a very vulnerable place to be for most people that are coming in with these wounds. They're full of shame and they've been disregarded many times through the system. And so Rachel builds a wonderful relationship with these, with my peers. And once she calls me and I know that she's calling because she feels this person needs to be seen, I know that, it's time, that there's this window of opportunity that I feel is very crucial. And that's when I feel the engagement is really important for what I do. So I will get on the phone with the patient and speak with the peer and, engage about, how they're feeling and what's going on. And if they're safe to come in, which way they want to come. They want to come today, they want to come tomorrow. And we build a little rapport and I give the power back to the person when they want to do this. And usually it's right then and there because, they've already built this rapport with Rachel. And so when we get them into the ER, at that point, it's very important for me to have someone to follow through with this because it's a big responsibility to say, come on, come in, trust me, we'll get this taken care of. We're not going to discharge you. We're going to make this happen. And, it puts a lot of stress on you to think, God, if it doesn't happen, where's this person going again? But I feel like the team I have now at Penn, working with Josh and social work, Angela, we have built such a great relationship that, I'll be able to call ahead of time and say, listen, I have someone coming in. Do you think you guys have the capacity to do this now? And I'll give them an assessment over the phone that they're on their way so that we can get prepared for, the process of, whether it's MAT, whether it's not, how much they're using, when was their last use, will they be in withdrawal? Will they, do they want to go inpatient? Like there's a lot of questions that, that they start to talk about when they're on their way on the phone. And once they get here, there's a lot of anxiety. So I have to mitigate that anxiety level. So to let them know that, don't worry about, whatever's being said, I will walk you through this. You won't have to worry about answering questions right off the bat because I feel at first they're very, afraid to come in. And so when they get to the door, there's security, of course, which people are triggered by that and will leave AMA once they see that. And, and a lot of times they have, items on them that they don't want, the security to get, or they forgot that was on them. So we make sure that we clear that before we come in. So there's no, I feel like the anxiety at that point would cause the person to leave. So I try to take care of that first. Then we will go through registration. A lot of times people don't have insurance, or they're not able to find their information, or they don't have an address. It's very hard for people to remember what address they last used. So I navigate people through the system at first, which is security, then registration, and then we hit triage. And then at that point, I am in contact already with Josh. I remember the one day when this particular lady came through, it was so severe, the neck wound, that, I don't usually get startled by them because I've seen them many times and I have had one myself. I was really nervous that, this may not happen. And I go running through the ER to make sure that he was there, because I already contacted Angela from social work to let her know. And then I look around the bend and I see Josh, and I'm like, there is a God. And the other provider starts to laugh, because she's like, she knows what I'm talking about, because, it's not everybody can do this work. Not everybody's cut out for it. That's what I can say. And, the patient was brought in and treated with compassion, and, people were able to respond. I'm able to go over and write a note and put in my thoughts of where this person was, and maybe they have a nurse that they contact, or maybe they have a social worker in the area. So I like to put a note in so that other providers that are going to work on this particular patient will have a full background of what's going on, and how they can be, best help them. And that's right where I'm about. Next.
I just want to pause for a second for everyone to appreciate how much time and, very thoughtful coordination has gone into this situation, by Kelly, just getting this woman in the door, and how many times Sarah would have turned around if Kelly wasn't there. I mean, this is we haven't even reached the medical care piece yet, and already Kelly's made a huge difference. So putting on my Penn ED nurse hat, similar to Josh, medical aspects of this neck abscess. Sarah needs labs. She needs a CAT scan. I need to get her antibiotics. I'm worried about her pain and what kind of wound care she's going to need. But there's this person at the center of all of this who's very scared because she has this scary infection on her neck. She doesn't know if or how we're going to treat her pain or withdrawal. Is she going to be admitted? Will she need surgery? Can she trust us? All of this. And a person who is scared is going to be very hesitant about all of these interventions that we want to do. And the ER normally deals with this hesitancy by saying, oh, the patient's refusing care. And again, making judgments that Sarah doesn't care about her health because she's refusing care. Why did she even come here? But then again, here comes Kelly, who helps this woman understand what's going to happen, kind of what to expect, and to reassure her that she's got people on her side. But also Kelly's letting me know, hey, what Sarah's really concerned about right now is her pain. And Sarah may not feel comfortable telling me that because in her experience, best case scenario, we ignore her pain, and worst case scenario, we're all going to think she's drug seeking. But now I have that information. I can bring it back to Josh and say, look, she's just in a lot of pain right now. And I think if we can get her more comfortable, she'll feel better about going to CT and, going along with all these other things that we feel are important to do and are important to do. So Kelly helps us walk that line between facilitating care and also making Sarah feel safe and supported along the way. Next slide.
So in a situation like this, I always receive a warm handoff from Kelly, just kind of explaining what's going on. There's always, of course, a lot of different providers, a lot of different people coming in and out of the patient's room. So I just try and go in and let them know I work with Kelly, let them know she told me about them, and I'm just there for an added layer of support. And then before they get admitted, I dig a little deeper with them, just regarding their patterns of substance use. When was their first use? When was their last use? How much are they using? Is there any other substances they're using? And if they're interested in medications for opioid use disorder. And also just, what can we do to make your stay here successful? We want you to be comfortable. We want your needs to be met. and we want you to get the treatment that you need. So what can we do as a team to make that happen? And then I put that all in a very detailed note normally. That way it really like takes the weight off of a provider, the admitting team. They don't have to go into detail about their substance use. I've already done it. They already know now from my assessment that they are interested in, medication assisted treatment. So it just makes their lives easier and makes it easier for them to acknowledge and recognize the opioid use disorder, and make a plan that's going to work for the patient. Next slide.
So Sarah had a great outcome, to cut to the chase. But going back to what I said originally, historically, a large proportion of patients like Sarah would have either left before even coming in, as Rachel said. They would have come into the emergency room and their pain and or withdrawal would have been ignored, and they would have left the emergency room halfway through their evaluation. And best case scenario, we get them admitted, and then a lot of times patients such as Sarah would leave against advice once they're admitted for 24, 48 hours, again, because either their pain or their withdrawal is not being managed appropriately. With Sarah's case, she already had a pre-existing relationship, which was really helpful. Again, before she even hit the door to see me, she had already known Rachel. She had already known Kelly. Kelly met her at the door and brought her in. And we already had this huge wealth of information about her history of her use and what she preferred and what she needed ahead of time. So this isn't even something that she had to be asked while she was in the emergency room. We already knew this. And so having that pre-existing relationship really got her to come in the door and really get the process started. Having Kelly there and with Kelly and Angela as her kind of support, she was really encouraged to stay. This was not a completely smooth process. She was very hesitant with multiple stages of her evaluation and care. But she got a lot of peer support, both again through Kelly and Angela, that Rachel and I, as the bedside, as the nurse and the physician, we have other patients. We can't be at the bedside all the time. And so a lot of that support and encouragement was provided by Kelly and Angela. And then they continued to follow her journey. Like, this doesn't end in the ER. So she got admitted. She had to have surgery. They followed her journey throughout the hospital. And so we identified early on that she had a huge abscess to her neck. This is acutely painful. And so she had acute pain. And so her symptoms were managed with IV narcotics and then methadone, I believe, for MAT. And she was eventually got surgery and was transitioned to methadone and continues to be followed as an outpatient. And so this is someone, again, who had a pretty significant, and I would argue at times, life-threatening medical problem that we were able to get into the emergency room, get appropriate care, but also for her abscess and her infection, but also really address her substance use as well in a really appropriate way for her. The next slide, and I love this. I love this. The second case.
Thanks, Josh. So this second case is about Joe. And I often work in triage as a triage nurse. So I spend a couple minutes with every patient who comes through the door to figure out how sick they are and how quickly they need to be seen. And so Joe comes in, he's like pretty well appearing. He's friendly, he's cracking jokes. He tells me he got kicked out of his housing because he was using opioids. Now the ER nurse, triage nurse in me assigns Joe an ESI of 5, which means I predict that he will need no ED resources, no lab work, no medications, no X-ray or CT, specialty consult, any of that fancy stuff. And sometimes we call these folks respite patients. So we'll offer them some food and some toiletries, let them rest for a bit, but then we discharge them. Next slide. But discharging patients back to homelessness can be very hard for nurses. And definitely the same goes for anyone with an active substance use. So here you have someone experiencing both of those. And I know that the ED can't fix everything for Joe, but watching people re-enter the challenging conditions and environments that he's trying to get out of, he's reaching out for help. that really digs at you. And I think a lot of ED nurses cope by withdrawing emotional engagement from patients like Joe. And it's a defense mechanism, but certainly does nothing good for our patients or for us, for that matter. But then to know that this person has meaningful follow-up with a peer who we've seen in action, we've seen the amazing connections Kelly can make with people, it's such a relief, and it plants hope. And that is a kind of hope that we can extend to the next patient like Joe. So it kind of breaks this cycle of emotional disengagement and inspires us to reach out a little bit more. And I realize I gave away a little bit of the ending here, but next slide, back to Josh.
No, I think it's completely okay to give away the ending here because it makes me a really happy case. So from a physician's perspective, patients like Joe, again, as Rachel said, respite patients, as recently when I started practice or, only a couple years ago, if you see a patient like Joe pop up on the board, it's an easy patient. I mean, as Rachel said, that is a patient that historically has required no medical intervention. And so as a physician, I need to do a medical screening exam. I need to say hi to Joe. I need to listen to his heart and lungs, ask him if he needs any medicines or if he's having any symptoms. And the answer to those questions is going to be no, because, he doesn't have a medical complaint. And then as Rachel said, he gets discharged. It's a very quick interaction that historically has required very little cognitive effort on the part of the emergency physician. But as Rachel said, that's really at its core, it's a defense mechanism. We essentially are dehumanizing these patients and saying they don't have a medical complaint, so they're not worthy of my time to see if there's anything else I can help them with. And it allows me to basically see that person and move on and not kind of think about them as a person and what they need, which again is a really dehumanizing way of looking at people. And so, again, I don't want to give away the ending here. I think Angela and Kelly will handle that. But you'll find that Joe is a success story. And they were able to do some really wonderful things for him. And I think what that does from a physician's and honestly from a nursing standpoint too, is there's a shared success in treating patients like Joe. In that if he has a good outcome and I have had a hand in his care, so in other words, I talked to him, I chatted with him for a little bit, even if I'm not, again, providing life-saving medical care for him like I was with Sarah, if he goes on to have a great outcome and at the end of the day is discharged with a positive outlook and a good plan in place, I inherently as a physician am going to feel like I did something for them. When in reality, I did no work and all of the glory should go to Kelly and Angela. But when you work as a team in the emergency room, every patient that you have a hand in that has a good outcome, you inherently feel there's a shared success there. You feel like you've done something good for the patient. And so whereas historically patients like Joe, I would have seen and forgotten about 5 minutes later, a patient like Joe, I'm going to see it. I'm going to think about it in the morning and say, wow, we did a good thing. When in reality, again, I admittedly didn't do much, but it feels like I did a lot. And that's a really uplifting feeling for medical providers. All right, so now you get to hear what actually happened to Joe. The next slide.
Thanks, Josh. So as you guys know, Joe came in just for experiencing homelessness, didn't really have a lot of complaints, but that is a normal scenario that would warrant a social work intervention. So, and by, engaging and talking with unhoused individuals, you really get to learn their story and their specific situation and their specific needs. And in this case, specifically, it was Suboxone. He had just recently lost his permanent shelter bed. He said that he was previously on Suboxone. It worked well for him. Had no idea that getting Suboxone at this ER visit was even an option for him. So, we educated him on the possibility of that. I contacted Kelly, who was then able to speak with the patient over the phone and kind of create a plan for follow-up. So historically, that would be really difficult for a patient experiencing homelessness who doesn't have a phone. You're trying to schedule them a doctor's appointment or a meeting, and it's just, you're really just like crossing your fingers and hoping that they get there or go. But recently we received a grant for phones, like track phones for patients that are experiencing opioid use disorder. And so we were able to get him hooked up with Kelly, get him a track phone. And, we literally, every time we do this, we put Kelly's number as their like only contact in their phone. So they don't lose her number. And yeah, he was able to, meet with Kelly the next day. We got him a bridge script to go home with, and I'll let Kelly explain the rest of the follow-up from there.
Thanks, Angela. Yes, that's awesome. I mean, it literally, like, the minute you put me on the phone with him, like, he really wasn't able to engage much, and which I feel like my part in this is to, like, advocate for medications. But in this case, Angela already knew to do this, which was amazing. And it felt so good to be able to now, pick up from there and able to move on to the community, which why community CRSs are so important, because outside of the hospital, we can follow these patients. And I followed him for now 4 months, which is amazing. He was able to get my phone number, of course, every day, faithfully. Joe's calling me to check up, and I'm so happy because I feel it even gave him, like people take, I think, technology for granted and think that everyone just has it. And working out with the homeless for over a year, realizing that like phones are just really not, there's no phones, there's no pay phones, there's no way of making connection with the world. And, being in addiction like myself, I disconnected from that world, just being from suffering from that. And let alone when you detach from like the technology part, it's like you're really underground at this point. You really don't, have any way of making appointments for yourself or maybe changing them. And so when he was able to get out the Suboxone, she was able to get a week bridge, and we were able to get him to one of our providers at Penn. And he called me the day he was supposed to come, but something happened because he is living in a shelter, which I was just grateful that he had that as well, being able to go back to the shelter. And Joe was able to call me to let me know that there was some kind of weather problems or something happened and he couldn't make the appointment. So, our wonderful providers that we work with were able to like bridge him again for several more days, which is so important, the bridge prescriptions. And at that point, I was able to stay engaged with him and the doctor to let him know what was going on with, he had issues going on with his daughter, and there was a lot of other things going on. And usually calls me on the train because I sometimes can't hear anything. But, he's on the train a lot, and, he was able to make it to the next appointment, which was great. That was the first time, I think, like in a month, I think, because it went about 2 more times after that, and that I finally met him face to face. And it was awesome. It was just great that we were able to build a relationship just by technology and to do telemedicine like that. It was very important. It happened at a perfect time with COVID. And, I hope it continues because it really does work. He's 4 months now, still going to the doctor and, engaging with the CRS, and he's still at the shelter. And, he's doing well. I mean, he has already had a hospital stay where he came in, and the same provider was able to follow him through the hospital system because, it's pretty much we have to navigate the system and advocate. And that's what CRSs mostly do at this point when it's someone in the community that has to come into the hospital system. So Joe's doing great. And yeah, I'm so happy that this story was one of the ones we spoke about because, it's just a great hope story. Thank you. Next.
So just to piggyback off the technology aspect that Kelly was talking about, in any other scenario, if Joe didn't make his appointment, the provider would have thought like, oh, he didn't come because he relapsed or he doesn't want to go into treatment anymore. But really it was like a weather issue or something crazy that you just wouldn't be able to communicate to somebody if they didn't have a phone. So like the phone part is so important. Yes. So as you've all really got the gist, Joe is still doing super well. He still uses his cell phone. We re-up his minutes every couple months. He stays in contact with Kelly. He engages in the medical care. He's stable on Suboxone. He's well connected to all the resources that he needs. So it's just a really great scenario of how this team approach is so effective, especially with Kelly being able to be that bridge to the outside of the hospital. Next.
So again, I love Joe's story. It really is heartwarming. So I think, in summary here, I think the big things that, at the end of the day, we recognize is that recovery, much like for patients who have opiate use disorder, is a process. Kind of breaking down the stigmas in the emergency room is also a process. It's not something that's going to happen overnight. It takes really dedicated effort by a whole team of providers over really quite a long period of time to really, again, decrease those behaviors, decrease the language, and really make these patients feel comfortable again. It's really important that we remember that we are trying to meet people where they are and not where we are in the emergency room. And we do that for other patients, but historically we haven't done that for these patients. And so that's one of our big goals at the end of the day, and one of the things the recovery specialists really help with. I think, most importantly for me to remember day in and day out, and I think my colleagues here would agree, is that at the end of the day, 100% recovery rate and a 100% success rate for these patients is not realistic. If I went in every day saying that every patient Kelly brought to me, every patient Angela saw and let me know about is going to end up, stable on medical assisted therapy with outpatient follow-up, that's not realistic. But what we can strive for and what we really should be striving for is, as an ER provider and as an ER team, is that 100% of the time, these patients should be met with empathy, sympathy, and compassion. And we, on our end, should be setting them up for success every single time we see them. And so again, that's putting the onus on us to really help them with their care, rather than viewing it as them not succeeding in their recovery. Again, some of these patients, this is essential. Joe is a wonderful story, but at the end of the day, still didn't have a true medical complaint. But for Sarah, medical care was essential for her. Having seen the abscess that she had she not continued with treatment, she very likely would have been facing a life-threatening medical problem. And so again, we're not shooting for 100% recovery from our patients, but we're really shooting to treat every one of them with respect, compassion, and the time that they deserve. And that's really what goes in to an effective team environment, honestly led by a peer and recovery specialist. Next slide.
Thanks.
I think the next slide is questions, right? Yeah. So there is a chat box. I think, Nicole, if you want to read the questions of the chat box, or honestly, if people want to unmute themselves, I think you can do that as well.
Thank you. And thank you, everyone. That was amazing. Our first question is from Jean Marie. She says, sharing positive stories is such an important way to break down stigma. Do you have a strategy to give follow-up to providers, especially new people outside of the inner circle of advocates? Josh and Kelly, I think that's a good question for you.
So, go ahead.
There you go, Josh.
Yeah, so again, I will say as recently as a year or two ago, I was not one of the inner circle of advocates. I don't even remember the first time I met Kelly. And I think it must have been like a weird interaction to have someone just randomly come up to me in the ER and tell me all about a patient's history. But I think to Jean Marie's question, and again, I think Kelly's the one that really can detail the strategy, but I think one of the biggest things that I've seen her do and her colleagues do is when they have a success story, or a patient is compliant with follow-up, or they have a good outcome, the next time they see that provider, they will let them know about it, right? So in the ER, we're not blessed with follow-up for most of the time. We see a patient, we treat them, and then we don't ever see them again. But when you hear, and most of the time when we hear about a patient, say, hey, Josh, do you remember that patient? It's because someone's about to tell me something bad that I missed or I messed up. And so when Kelly and her colleagues are able to say, hey, do you remember that patient? They actually had a great outcome. That's a really powerful tool to loop someone in who may not have previously had much experience with these patients and caring for them, and really get them excited and feel good about the work that they did. And that, has downstream consequences in promoting positive behaviors.
Yes, I feel like, and that's true. It is not always a success, but sometimes when they leave the ER, they it's already been planted. The seed's already been planted. They're already in the motion, but yet it's not quite, happened yet. The appointment, the outpatient appointment, and then eventually it does happen. And I had someone recently that it wasn't a good outcome in the ER, but once they left, they already realized that they were ready for the MAT, and they went on it, and now they're 4 months. They have a child. Their partner is in recovery, and they're doing really well. And how could I not go back and tell the doctor that maybe felt like they didn't do the right thing for this person, but in all reality, they did. They planted that seed already by offering the MAT and realizing that maybe this person just needed like someone to just care for them at that moment.
I just want to comment, that's great. Our student commented that compassion is an intervention, whether continued engagement happens or not. And to your point, I think that is what our patients reflect on when they leave. Was this a place that I felt safe, and would I go back to this community of people who could help me if I need help again? So really, really important. Thank you.
So just to add to that, I know that normally in the ER you don't see people again, but we recently had a patient who came in severe withdrawal. He was stabilized on Suboxone, and then came in, just so happened the same provider was there, but he was still stable on Suboxone. He came in for something completely unrelated to opioid use disorder, and that provider was able to say, like, oh my gosh, like, look how good they're doing. Like, they came back because they still, like, it's still a matter of trust and compassionate care. So they came back to them because they appreciated the care they got, whether it was for substance use or not. So
if I can jump in real quick too, I think it's, important to remember that we're not advocating for crazy things. This is like very common sense, basic medical care, pain management, like be a nice person. And I think even though the barriers seem really big and stigma is really hard to come up against, when you just center back on that, like this is basic humane care, it can make it easier to approach those people and those conversations.
Such great points. We have another good question in the chat from Brittany. She says, I'm curious on how each of our panelists navigate around clinical staff that may present signs of stigma towards patients, from peer to provider and also provider to provider. How can we productively and professionally mitigate those situations?
Well,
This is such a go ahead, Kelly. Kel, I think you're on mute.
Thank you. Sorry. I think just our presence being in the ER is enough to, I think, bring the awareness that, that there is hope and there is recovery and it is possible. And, that, once they see that, I feel like the more people we have, the more CRSs in the ER will show that. I feel like then, there's an example of, maybe if I do help this person, maybe it is possible. There isn't really any fine way to do that except by example.
Yeah, that's what I was just going to say. I think it really comes back to this modeling, like Josh said, and like I feel, I was not where I am now always. And so I try and look at my coworkers who are, who are struggling with the stigma piece, or, I look at them as like, potentially this person could change and, and be a much better provider to these patients. So how can I also kind of meet them where they're at? And sometimes it's not addressing it in the moment. Sometimes it's just like you step in and do it the way that I would do it, and they see that. And then sometimes it is like, hey, the right word to say is this. I think you have to not turn people off along the way if you really want them to join your side.
I think the other thing, from a physician's perspective, because again, we're talking about peer-to-peer, but physician to physician, provider to provider. it's really hard for someone like a social worker or a nurse to tell a physician, hey, you just treated that patient with disrespect, right? ERs have an inherent hierarchy, and it can be really intimidating for a person to kind of walk up to an attending physician and say, I don't think you handled that well. And so the onus then is on myself and my colleagues to really call out our colleagues. And I think one of the biggest ways that I've had success is, laying the foundation that almost none of my colleagues inherently want to treat people poorly. Like, no one's going into this saying, I, really dislike patients on opiates, and I'm going to treat them with disrespect. That's not really, it's more often that they don't know, and they're naive and they really are ambivalent towards it. And so what I will often do, in particular at Pennsylvania Hospital, where all the physicians tend to sit together in a row, is if I hear nursing come up to one of my colleagues and say, hey, the patient's complaining of pain, and then my colleague makes some comment of like, oh, they're an opiate user, like they don't need pain meds or anything like that, I can casually say, hey, did you talk to Kelly, or did you talk to the patient about Suboxone at all? And it's a casual conversation, like, hey, it sounds like you're struggling with this patient. Did you, there's some other options. Sometimes, my colleagues will ignore me, and that's okay. But, every once in a while, if someone had never interacted with Kelly before and then decides, who's Kelly? And I give him Kelly's number, and, she comes and says, hi, you can make that connection. And then that person then says, hey, well, that was a great experience that I had. I never knew this resource existed. And then the next person that they see, they're going to start using those resources. And so, sometimes it's just the subtle things of nudging, our colleagues to kind of know what's available to them, rather than continuing to live in the ignorance.
I like to just engage them in conversation, like give them some back history about the patient. Don't let them just like judge the patient face value. Like, I'm not going to go up to the provider and say, like Josh said, like, I'm not going to say, I don't think you handled that well. But I could say, actually this patient had, 2 years recovery. This is new. Like, they have goals, or this is something that happened to them. Like, give them some story to help them look at this patient as more of a human being. Because that, like Josh said, nobody is in medicine because they don't like people or they don't care about people. They're just looking at it from a different lens than Kelly or me. So I think engaging them in conversation and just a dialogue is super helpful.
Thanks, Angela. We have a big question with many layers in the chat from Donald, but we are fortunate because we have some of the experts here that started the inception of the program. It says, how many peers do you have on the team? Describe supervision in an organizational readiness assessment before integrating a peer, and did you use any toolkit or framework for the integration? Are your peers paid a living wage with benefits? And we have Dr. Perrone and Dr. Lowenstein here, that if they have a chance to unmute, I know that there was a survey done before we started implementing peers that Dr. Lowenstein published. So if she's able to talk about it, but I know Dr. Perrone can too, to answer some of those questions.
Happy to say a few words. Sure. Nice to see everybody. So the survey was, I think, one of many pieces that we did to prepare for some of this. So we did a survey of emergency physicians to ask about barriers and facilitators, both to just providing OUD treatment in the ED, and then more specifically to, some of the details like getting their X waiver. But I think what was really the big takeaway from that survey was that, the biggest barriers to starting medications really were not about the details of the medication, but it was much more about all these other pieces, like the social context that the patient was struggling with, getting them follow-up, helping them to plug into resources. And so I think that really supported the idea that we needed a team of people who were really expert in engaging with patients and addressing these issues. And so that was, I think, a big part of the work with peers. And then we worked with the Innovation Center at Penn, which is a group that kind of helps do a bunch of piloting and kind of trial of cool different interventions. And we did shadowing, we reviewed some of the data, we looked at a lot of different pieces, but I think I think it was really clear that this was a big void that needed filling, and that we needed to get peers really front and center in order to do that, because it wasn't necessarily integrated into the ED teams up front, or it hadn't, and in the past, historically, they hadn't been members of the team. And I think the other piece is just making sure that their peers are fully members of the team. So having access to the EMR, having access to the building, like they don't have to ask security to get in. No, and that allows people to really become a part of the team fully. And I don't know, Dr. Perrone, do you have things to add?
I think it's a great question and a great answer. I'm involved in a big study around the country that uses peers, and I think, like you said, Maggie, peers that are rotating amongst hospitals in different health systems, I don't think they have enough of a feeling of being part of the team where they don't have full access. I think, our program has grown. We started with really with just one peer at 2 hospitals, and, has grown to add, Kelly and 2 or 3 others at this point. And so I think organically, as the value of peers became more apparent, it became more of a necessity that drove, the expansion and the implementation. So I think we're still really working on that value, and we're the insiders, right? We already love the peers and know how critical they are. But webinars like this and spreading the word is really our goal. In our next efforts is really to kind of prove, in the way that you have to do sometimes in healthcare, the value of peers in order to get them funded and available, at more programs around the country. So I think we can thank you all for joining. You obviously have an interest in this, but also, disseminate our work. Hopefully this webinar will be posted on our website, and, hopefully we can share it widely with other places that are interested in this, both the important problem of stigma, how to mitigate stigma, the role of peers in stigma, but also just the role of peers in this whole continuum of bringing people into treatment, which is now more critical than ever with COVID disparities and rising OUD deaths again. So just want to thank everyone for joining and the amazing panel. I learned so much, and I'm deep in it. And Kelly, that navigation of security and registration was really eye-opening to me. So, I can't thank you enough for all the work you all do.
I also, if there's time, I have a quick humorous story to end at Kelly's expense. Sorry, Kel. She knows the story I'm going to tell. So, going back to the question of how do you loop people who are not in the inner circle. So I met Kelly, once or twice, and I didn't really think anything much about it. And then Kelly, I guess, identified that I was, up to the task for caring for these patients. And so she called me, like I'd met her maybe once or twice. And so I wasn't fully in on the inner circle yet. And she called me and said, I'm sending a patient in, and they'll be there in 10 minutes. And so patient comes in, and the triage note for the nurse says, patient here for opiate use disorder has pound cake in hand for Dr. Glick. And so they call me, and I come out to the patient, and she had a pound cake from Stock's Bakery in North Philly with a note that said, hey, Josh, thanks for taking care of this patient. And at that point, I kind of knew this is a special community, and Kelly and I have been best friends ever since. So, you want to talk about, it's little things like that, just really loop people in, and I've been looped in ever since. So, the credit goes all to Kelly, her colleagues, Jean Marie, her colleagues, and those of us on the clinical side really benefit from their hard work.
Thanks, Josh.
Oh, well, thanks
you,
everyone. And maybe just there's another webinar in 6 weeks or 2 months